what your parathyroid glands do. Think how important calcium and magnesium and phosphorus is in the body. When these are all dysregulated, things go haywire with internal. And if you remember the kind of blood labs, the biochemical markers that you order, all this kind of the electrolytes and minerals and those kinds of things. But what's really big is the bone density, the bone mineral density. Osteopenia, osteoporosis, osteomalacia. What is if you're a child and you have osteomalacia, what do you know about?
Osteoporosis. Osteogenesis imperfecta. No.
Osteogenesis imperfecta, you can use some sort of you're loose sclera, you might not survive childbirth, because you have rickets, bendy legs, and then Paget disease can happen. So men's syndromes, men 1, 2, 3, 4, used to be 1, 2A, 2B, and 3. Now they've reclassified. But it's a predisposition for tumors involving 2 or more endocrine glands. And they're just called men's syndromes. And I think you've seen some of these on pharmaceutical jingles on television as well. I keep referring back to that because every once in a while when you're exhausted, that's what you watch. And they'll say, oh, you know, this might predispose you to, you can't take this with multiple endocrine agents. But it's autosomal dominant, it's inherited. And if somebody's parent has this, it's first degree relatives, you need to check that other patient out. If a mother or father has it, check the children. If those children have it, check their children. If the grandparents have it, check the parents. Because it's that inherited. People don't live long with some of these things. So carcinomas affected glands, genetic testing is a must. Not genetic testing that the individual has this, but for their offspring. It's very, very important. All right, so men 1. Multiple endocrine neoplasia type 1, tumors of the anterior pituitary thyroid glands, and the pancreas. They've also added the duodenum to that since they touch, since they communicate with one another, because there's pancreatic enzymes actually flow into the duodenum to break down substances. So think of the 3 P's. Just think. Pituitary gland, parathyroid glands, pancreas. This one's in those syndromes, this is the common one. Usually detect them by the time you're, you're into your adulthood, your 30s or 40s, but some of these are detected before you're age 15, about age 14 or so. So usually people present, here's a 14-year-old or comes to you, or an 18-year-old comes to you with hyperparathyroidism, so something's wrong. So you already know you've got a disorder of mineral metabolism. Something's happening. So what are the parathyroid glands? What are the 2 hormones? Well, the one hormone that you're looking for in a parathyroid gland, the hormone that regulates the calcium. And where do they get the calcium from? If you have too much circulating calcium in your bloodstream, it comes out of your bones. Hypercalcemia. Life expectancy just in the 50s of that. That's not good. Men 2, medullary thyroid cancer. Now remember, what did we think? In the grand scheme of the thyroid cancers, you've got differentiated cell thyroid cancers. There's 2 forms. Do you remember what those are called? One is the more common form, papillary. And then there's another, I know you're working on this stuff. Papillary, follicular, good. The next step, and those are all aggressive. Papillary is not aggressive, tinge aggressive for follicular. Medullary thyroid's the next one, it's aggressive. It's not as aggressive as the worst one. Which is the one with the worst prognosis?
Anaplastic.
Anaplastic. Greatest risk for mortality. Not a good one. So medullary thyroid cancer, pheochromocytoma. Where do you find that? It's not, I'm aware.
Adrenals.
Oh, excuse me.
Adrenals.
I mean, adrenal glands, but specifically what part? Your medulla? Good. Primary hyperparathyroidism. So here we go again. The thyroid, the adrenals, parathyroid glands. And this one's bad. Thank goodness it's rare. It's very rare. What is an ganglion? These people present with Hirschsprung disease. Is that ring a bell? What is that? It's a ganglion colon. What does a ganglion colon mean? You're constipated because you can't peristalsis. There's a portion of your colon that has no nervous system. So things go to a certain point and they stop. There's a section that's aganglionic, they have no nervous system, and then there's the rest of it's paracelsus along. When we do in surgery, we take that section. You never dose, what does GLP stand for? Glucagon-like peptide 1 agonist. We never dose those meds, those type 2 diabetes medications, the oral, because it increases that risk for medullary thyroid cancer. We've got multiple there's nodules on that thyroid, let's see the parathyroid, we've got hypercalcemia going on. Phenylchromocytoma, what are those patients' symptoms? Do you remember? Their whole body's out of whack and it's racing. So think of it that way. They're sweating profusely. They've got these periodic or episodic headaches. Their hypertension is paroxysmal or sustained. Their body's going crazy. It's going haywire. They can't slow it down. They come to you jittery and anxious. Something's wrong. Heart rate's up. Blood pressure's up. Phenylchromocytoma. They could die within 24 hours if you don't stop this. The heart's just racing. So screening for phenylchromocytoma medullary thyroid cancer, especially prior to a surgical procedure. Remember, we have to have an alpha and a beta blocker before we go get that adrenal tube for phenylchromocytoma. Okay. Chromatin cells of the adrenal tube. Men-3. Medullary thyroid cancer, phenylchromocytoma. But there's all kinds of other weird things. There's ganglionomas in the intestines. What is bronch, man? You have a bronchinoid. No, you go taller on you. Oh, there you go. Texas excavatum. Long arms and legs, usually pretty tall. We used to say piano player fingers, really long fingers. Is there coarctation of the aorta? Are there some other things, some other coarctation of the aorta? And what I remember from the PCO and DBs ago? Delayed puberty. So there's, look at this one, bumpy and enlarged lips and tongue. There's these mucosal types of neuromas, mucosal masses. Something's wrong. Then syndrome. Medullary thyroid cancer is extremely aggressive and will present really young in life. So this phase is where it's here. And then there's MEN4, parathyroid gland, pituitary gland, adrenal glands, gonads, so ovaries, testicles, kidneys, that goes here. All of those are ripe for tumor. All of those are ripe for failure. When you have testicular failure or ovarian failure, it's hypogonadism. And there's lots of sequelae that happens because
Bless you.
you have hypogonadism, and we'll talk about that later. What do you think the patient's gonna complain of? They're an adult. Loss of libido, which is desire, erectile dysfunction, androgen excess perhaps, or androgen decrease, androgens. Ovaries, maybe cessation of menses. Is that primary or secondary memory? Talk about that. Things you gotta think. Then syndromes. Two or more endocrine glands that have the propensity, they have tumors, and they have the propensity to be cancerous. And when the cancer hits, it goes really quick. So disorders of mineral metabolism is everything we've been talking about in endocrinology. When the parathyroid glands are acting up, you've got a problem with your calcium, with your thyroid hormone. When your adrenals are acting up, we have hormonal issues with aldosterone, cortisol. Your thyroid's acting up. It could be the issue with the pituitary gland, which you've got some hormones that are all messed up. But when those hormones are kind of skewed and they're dysregulated, then your minerals are dysregulated, and it can lead to things like osteopenia, osteoporosis, Paget's disease of the bone, which is soft bones. Osteogenesis imperfecta, there's two forms of that. One you don't survive and one you might survive. Do you guys ever see the St. Jude commercials on TV? These are always I don't watch a lot of TV. I watch the Food Channel, obviously. The really cute little kid who's sometimes in a wheelchair, and he actually works for the Dallas Mavericks right now. And he's a cute little guy with a he's like their spokesperson. He's like, you know, for your donation, you get this teddy bear blanket or this really cute little guy. That's osteogenesis imperfecta. That's what he is. And he's actually, his dream was always to be a WNBA basketball player. He works for Mark Cuban, and he's a manager, or he does something, and he's just living his dream. But he is a survivor of osteogenesis imperfecta. He lives in adult now. He's 19 years old. Those things, anything endocrinology wise that dysregulates, that has dysregulation of hormones, will eventually and does attack those minerals. So chronic kidney disease doesn't help either. That really messes things up. Chronic kidney disease really screws up those electrolytes. The electrolytes are really messed up. We go on dialysis. Try to keep some of the electrolytes, pull some off, leave some in, pull the fluid off of you. Vitamin D, phosphate dysregulation, calcium phosphate, homeostasis dysregulation. This is kind of, you know, this is what happens in endocrinology. And you see all these disease processes, and this is what happens. Calcium regulating hormone dysregulation, we've got thyroid hormone, vitamin D, calcium, fibroblast growth factor. But people, usually when they've got disorders of mineral metabolism, those serum calcium levels, well, they can also have a high serum calcium levels. We've seen that with hyperparathyroidism, hyperphosphatemia, and vitamin D deficiency. Bone mineral density. You've probably done this with gynecology. It's so much for you. Maybe you have, maybe you haven't. Yes. Frax. Did you go through Frax? Which is a scoring tool? Okay. B&D, bone mineral density. Frax is fracture risk assessment tool. The older you are, the older you get, the more your balance shifts. And it's not on the top heavy and bottom, not that kind of balance. You just lose your balance. If you're not exercising all the time, and if you're not doing resistance training, if you're not doing some kind of cardio, if you're not doing balance training, you're a fall risk. Because as you get older, you kind of lose that balance. So you're males and females at risk for bone fracture. So DEXA, it used to be DEXA, now it's DXA. That's the scan, the super easy machine that you just lay there and let them take a mineral bone density of your hip or your wrist or your vertebrae. And it gives you different normal ranges for every bone in the body, but it only looks at a few of them, but it's going to calculate for all the bones. Because people have hip fractures, femoral neck fractures, wrist fractures, spine fractures, especially older women. You know why your mother's so short or your grandmother keeps shrinking? It's bone mineral density. I bet you she has a lot of vertebral compression fractures. She doesn't even know it. Ask her backwards. Yeah, it's always nagging me. Bet you she's got some fractures back there. Kyphosis is another clue. Probably have some vertebral fractures. Z-scores and T-scores are what DEXA scanners use. And a Z-score says, here's that patient's bone mineral density related to standard deviations that match means, not averages, but the means of age, means of gender, and means of race. Not the averages, but the means. So you collect all this data, you sample the two different groups together, and you get your mean. D-scores and T-scores. T-scores do the same thing related to younger ages and gender. Low T-scores are either osteopenia or osteoporosis. Osteopenia, both preventable. They're actually preventable. Well, we can treat them too. Fracture risk increases twofold for every standard deviation drop in our bone mineral density. So as you get older, it's really important that you've got vitamin D in your system, because vitamin D is for mineral homeostasis. It works in the kidneys, and it's the only way you can retain your calcium. And the biggest problem with osteopenia and osteoporosis, osteomalacia, people don't have enough vitamin D, or they're not taking in enough dietary calcium. And that's a big problem. So here's your normals. If you're greater than or equal to -1, you're normal. If you fall somewhere in between -1 to -2.5, that's osteopenia. less than minus 2.5 is osteoporosis, and also less than 2.5 is fracture with severe osteoporosis. Right? I gotta put that. Know the normal. It's really important just to know the normal. Because you know if it falls, the numbers get lower, you're going to osteoporosis. And you're a higher risk if you start having fractures. If you have osteopenia and you start fracturing your metatarsals, where are your metatarsals? Where are they? Hands or feet? Their feet. That's a pathologic fracture. Pathologic fracture doesn't mean you have a cancer somewhere and it's bony mets. That means, let's look at your DEXA scan, let's look at your Z-scores, your T-scores. T-scores usually what we use. Oh my gosh, you're too young. You've got osteopenia, you're 40, you've broken your foot. No wonder. You're at risk. So the FRAX, which is your fracture assessment score, predicts your 10-year risk of hip or other major fracture that's due to osteoporosis. So it's useful for making treatment decisions in that patient. Oh, sorry about. What do you say? Yeah, 40s, 30s. So your limiter, you start looking at 55. When do I start estimating what's menopausal? So many people are doing or menopause. Yeah. So look at menopause. A lot of men don't really go to this. So when we exited, they had prostate cancer. Good. I heard that loneliness in your seat. Does that help? So the limitation of a fracture assessment score only looks at your criminal now. That's all it looks at. That's the one that keeps getting broken. You know why? Total joint over here. Why was the criminal that keep getting broken? We see a less propensity of it today. People aren't smoking as much as they used to be. Smoking really contributed. So the fracture risk assessment also does not take into account your alcohol consumption, your smoking history. Are you on chronic prednisone? Are you on chronic corticosteroids? What's your fall risk? What kinds of things do you think of at home for the elderly contribute to fall risk? Pardon me? Yeah, an area rug, especially a dark one in front of a door, looks like a hole. Cords across the floor.
Stairs.
Stairs, oh, that's my favorite. Stairs and 5 cats, that is my favorite. Because every time I walk downstairs, I'm like, one of them. They're trying to kill me. What else is a fall risk? How about somebody who's, they're off balance, and they're in the bathroom, and they're taking a shower, and it's a nice tile floor, don't you want some grab bars? It's not for doing parallel bars, and you and as a little kid doing backflips on it, that's pretty dangerous. Those kinds of things are a fall risk, so you want to make sure the house is set up for these folks. All right. Osteopenia. Low bone density, follow that for normal bones of a healthy young person. Remember your T-score is less than negative, it's -1.5. People are usually asymptomatic, they don't know they have it. Oh, you're postmenopausal, this goes, oh my gosh, but I eat cottage cheese and cheese all the time with my wine. Don't judge. No judging for those people. They're asymptomatic, let a fracture. What's happening? Well, they shrank a little bit. Last time I went for my annual exam, they actually said they shrank 3/4 of an inch. Oh, well, let's do a DEXA. We do DEXAs every 5 years. Or if you're at high risk. Maybe they got bone pain. If they have bone pain, that's because they have a pathologic fracture. That's why. So, what are the areas that are ripe for pathologic fracture of the vertebrae? Hips, the wrist, the ribs, the metatarsals. What's a Jones fracture? Man, that happens a lot. What's a Jones fracture? Fifth metatarsal. I've known people that step off the very last step on the staircase, twist their ankle and her snap. And there goes that metatarsal. Pathologic fractures, osteopenia. 40 years old. So the DEXA scan With that history, with your physical exam, that DEXA scan score, that T-score makes that diagnosis for you. Closely monitor for osteoporosis. Let's prevent this. Do you really need to treat osteopenia with any medication? Maybe get your vitamin D up, maybe make sure you're getting calcium, if you're lactose intolerant, you're not eating a lot of, calcium-rich foods, and it doesn't always have to be cheese. Aren't almonds rich in calcium? They are. There's other foods that are dark green leafy vegetables are very rich in calcium. Monitor them, because now that you have osteopenia, your risk for a major fracture it's at least. Osteopenia, let's look at just normal blood labs. Let's look at the CBC because you may have anemia. Maybe that's what's contributing to this. You might maybe we've got a kidney dysfunction. Remember chronic kidney diseases or other kidney disorder lend itself to bone metabolism issues. Just metabolism issues, period. Mineral metabolism. Calcium phosphate. What does albumin tell you? No, albumin. What does it really tell you? Nutrition. Nutrition. It's your protein. Like, how good is your nutrition? Are you going to heal? Doesn't mean you've got this white stuff in your body. Albumin. Alphos, what does 25-OH vitamin D? What is that? Hydroxy something, something vitamin? It's a very active form of vitamin D, but it's all the elemental vitamin D you're taking in, plus what you get from the sun. All you need is 15 minutes of sunlight twice a day to get that vitamin D. That helps all the vitamin D stores in its active form in the body. Good. So your frequency of surveillance, and this is kind of linked to that question that you have. Postmenopausal females, the older adult males, based on their T-scores. So if your T-score falls in that normal range, we just need to see every 5 years. But you start getting a few risk factors in here, your blood work's not looking so good, you're starting to be a fall risk. Then T-scores that start dropping maybe every 3 to 5 years, T-scores that are below -2, every 1 to 2 years. If you're a long-term pregnant and you look like a cushion-weight person, you're gonna have to see you every 1 to 2 years. What steroids do in the body? They work really well for things, but long-term, there's a lot of sequelae that happens. So if you've got somebody on long-term corticosteroids, or like bone fractures, osteoporosis, there's gonna be some other problems with this, not just the cushion-weight one. But when someone does a DEXA, the fracture risk assessment scores are also calculated.
Are you just as at risk if you have a shorter period of time? Or just, I'm not sure.
It's depends on your other risk factors and why you're taking it. Are you relatively younger and all pretty healthy? Probably not. And then once you stop it, then you want that risk. So prevention, adequate vitamin D3. That keeps your vitamin D levels above 30 nanograms per milliliter. That's what you want to be. Calcium supplementation if there's a low dietary intake. Calcium citrate is really, if you're going to supplement somebody, they make calcium citrate because it's got a lot of oyster shell in it. Good stuff. And if you could take it together with you, that would be even better. But stop smoking. Stop doing that. Stop. Lift your alcohol, do the weight training, do the resistance bands, do the walking, just the cardio walking. Remember what we said in diabetes? Hey, we're reduce your body weight by 5 to 10%, so 150 minutes of moderate exercise every week. Increase your progress. They say yoga and Reiki for older people. My mom, who's 87, does chair yoga. It's helped her balance a lot. She doesn't slide out of chairs, not that kind of balance, but it's helped her a lot. But for osteopenia, there's no long-term treatment that you need. Maybe you have to do something. You can use osteoporosis treatments. Someone's doing long-term treatments. Let's follow that same procedure. What do you do for? So here's the question was that, and what he was answered it correctly. What's the difference between 25-OH vitamin D and vitamin D3? Because a lot of providers put their patients on D3. Lots of international units, 30,000 international units, 50,000 international units per week. What's the difference? Well, hydroxycholesterol is 25 over time. Or it's called calcidiol. Calcidiol, I think there might be one other name, but it's the most active form of vitamin D in your body because it's whatever you're taking nutritionally and whatever you're directly from. Those added together of your stores. Vitamin D3 is a biologically active form, and that's cholesterol. And then a very active form of vitamin D that is man-made, hormonally activated. Synthetic. Vitamin D analog is your. So do you ever see what's the difference between that? Why am I taking this and not that? That's why. Osteoporosis. You've got a lots of bone matrix, which is your osteoid. Remember kind of layers that form your bones? Loss of bone matrix reduces the strength and integrity of that bone. So now you're really ripe for fracture. 1.5 million fractures annually. But again, your fragility and your fall risk increases with age. Of course, as you increase in age, ethnicity has a lot to do with fractures. Has a lot to do with gender. This is interesting too. Your risk is lower in blacks, lower in Latinos, lower nations, males and females. Frequencies will stabber in those ethnicities. You're more likely to see someone coming with a fracture who's a white elderly female. You're going to see, I have never seen ever in my career a hip fracture in anybody other than a white male or female. Never seen anybody else. I've seen more white females, but I've seen a ton of white males, elderly. I've never seen a black hip fracture. I've never seen a Latinx hip fracture. I've never seen an Asian. Their bone density is stellar. So your spine is more prone to fracture. Again, it's the same thing on the aging process, history of smoking, loss of sex hormones, alcohol abuse, long-term proton pump inhibitor. Did Dr. Noel ever talk about that? Protonics increases your risk, Prilosec increases your risk for osteoporosis. High dose steroids, of course. Prostate cancer. Androgen deprivation is key when you're metastatic. Right now, we're worried about osteoporosis too. Yeah, lytic bone lesions got mets to the spine, but we also worry about pathologic fractures from both processes. You've already said on the brakes. And it's varying degrees of severity. It could be a nagging backache to really painful back with a loss of height. So like I said before, it's compression fractures, the vertebra, it's kyphosis, they've already got some fractures. They're starting to shrink. Think of the quality of life that's impaired. I've lost my independence. I have a hip fracture, back fracture, lost my independence. I'm dependent on others to help me out. I can't drive anymore. I got to use a walker now, and that's really debilitating. I've got to be on a scooter. Don't care about, it diminishes quality of life. People die earlier. Mortality is high. They go away from their living situation into a rehab facility, and sometimes they don't make it back out. But always search for a reason. Look at the medications list. Look at the family history. Look at their history. Search for a cause. Again, we need the DEXA for diagnosis. We need the CBC. We need the BUN, the creatinine, the outfos. Your vitamin D scores, your levels, your parathyroid hormone, your hypercalcemia, or hypocalcemia. And then let's have bone disease. Non-pharmacologically, a diet rich in vitamin D. A diet rich in protein, a diet rich in calcium and total calories. So you look at that all given at your nutritional scores. Discontinue corticosteroids if you can. Stop smoking is the same thing. All precautions, more exercise, proper lit lighting, no loose floor rugs, those kinds of things we talked about. Pharmacologically, you want vitamin D, it's 600 units international use per day. The calcium up to 1,200 milligrams per day. Now, are you gonna ingest 1,200? You can have 1,000, but are you really going to absorb all that at one time? You gotta split it. Split it 3 ways or split it twice a day, do something, because you'll end up with kidney stones or really expensive. So you can't just take all of them. We're trying, it used to be we wanted women to 1,500 calcium a day, but that really made kidney stones. So spread it out. 1,200. And there are over-the-counter products. Caltrate is one of them. Oyster shell is in that, but it's vitamin D. It's 650 vitamin D, I believe, and something like 600 of calcium. You can take that twice a day and then you're done. Bisphosphonates. Those are good if you've got osteoporosis of the spine, femoral neck, or past fractures because of some low impact and it's back. So there's an IV infusion once a year. Quite a bit. There's an IV infusion that you could use every 6 months. There are medications you take monthly. There are medications that you just take weekly. Fosamax is a lot of ladies are on it. It's just it's a medication weekly. Actonel monthly. Boniva. Remember Sally Fields is on the end of the dock with her little Shetland dog, whatever she called her dog. Boniva, you know, she's once a month. Lots of medication. And there's ways to take it. So that's Dr. Noel's side. There's monoclonal antibodies, and then there's calcitonin. Calcitonin actually reduces pain because of fractures, but it doesn't reduce severe pain. So calcitonin is really good for that too. Not severe, chronic, ongoing pain, it's for pain. Osteomalacia, inadequate calcium or phosphate mineralization of that bone osteoid itself, so you're not laying that matrix down. And then you've got low bone density minerals again, defective mineralization, so that's bone mineralization, defective mineralization. It often coexists with osteoporosis. So we need that vitamin D supplementation. If your diet's good with calcium, you don't have to always supplement that either. It's just a basically definition. There's Paget disease, the breast, there's Paget disease below, Paget disease, this one is the bone. I've got some pictures that show what it is. It's called osteitis deformans. And it's one more lesion, one more bone lesions, having high bone turnover, so they're lytic lesions. I want to say, back when I was in high school, they used to say it looks like little rat bites or mouse bites taken out of these things. It looks like little heart-shaped little areas where things have been snipped out. These are lytic lesions. So it's more bony lesions, high bone turnover, disorganized osteoid formation. Bone pain is the first symptom. It's mild, it's asymptomatic, and also it hurts. And long bones are the first to have this problem. It's a deep, deep ache, especially at night. It's first symptom. But what's weird is you look at your calcium, your serum calcium, your phosphate, that's normal, but your alkaline is off the charts. Now, we had talked about this before. Alkaline in child's normal because your long bone growth is happening. But in an adult, it's not normal. High alkaline is never normal. You look for cancer, you look for something's going on. So there's fibrosis, there's bone tibias, a large skull. Your head's getting bigger. Deafness, fractures, because the bones get soft. And then they get thick. And then they get formed. So it starts proximal, long bones proximal to distal. So your femur at the femoral neck, distal to the tip. But look at this, osteolytic lesions. So you need your zoledronic acid, IV. That's that once a year preparation. Once they give this to the person, they give us one infusion IV and it starts putting your alphos back. It actually brings your alphos back to normal with one infusion. You've got great prognosis, but this can relapse. Here's what your bones look like. Look at the light. And it looks like little, if you look at the left hip especially, you know, you see a lot of, this looks like it's just ready to snap off. It's just not being filled in correctly. It's not a real tight mineral density. Looks like all these little heart-shaped, little roses, it's like little rat bites taking on the weird break then. It's a little, but look how big it is. But the outer part's the bone. So that's a dysregulation in the woman's balance. Any questions? Mental disorders, this isn't really one of them. Male hypothyroidism. Failure to testes due to produce enough physiological concentrations of your testosterone and or failure to testes produce physiological concentrations of normal number of sperm. So that's hypogonadism. So there's two forms. Primary is at the testicle, there's a problem at the testicular. And secondary is the hypothalamus pituitary gland, that's the problem. So that's the hypothalamus pituitary gonadal axis. So Klinefelter syndrome, cryptorchidism, what's cryptorchidism? If a child has cryptorchidism, what is they have a 10% risk of developing what later in life? Testicular cancer, we can sometimes see that with a hyperseal. Very good. Trauma, torsion, infectious orchitis. What's the most common viral form of infectious orchitis?
Mumps.
Good. The antipressoritis. So, think of your secondary characteristics when you have hypogonadism as a male. You're losing those secondary characteristics. You're losing hair, body hair. There's loss of libido, erectile dysfunction, gynecomastia. Who's gynecomastia? Enlargement breast. Yeah. Hot flashes. As well, hot flashes. Maybe depressed moods, decreased strength. A lot of them pretend they can't look like I used to be able to do. I can't like I could. Lost my vitality.
I make it there.
So, routine screening. We only do routine screening once it's testosterone. If you have signs and symptoms, that's not a routine thing that we look at everybody. So it is testicular failure and hypogonadism. So these signs and symptoms of hypogonadism. Low. Consistent low serum total testosterone or free testosterone concentrations. Primary hypogonadism shows low total serum testosterone, but your luteinizing hormone and the cytostimulating hormone are high. What are those hormones? Which part of the anterior, good. Secondary hypogonadism, rivers pituitary gland or the hypothalamus, low serum, low total serum testosterone, and normal or low luteinizing hormone. Remember, it's affecting that pituitary, it's not sitting at signal. Tons of therapies for the guys. There's brachytherapy, there's implants, seeds, and I know that one of my childhood friends is a interventional radiologist. Once a month, he has a line outdoor down the highway of men getting implants from testosterone implants. It's like the fountain of youth. Patches, gels. They know the gels. This is funny too. If you are putting the gel on the guy, wash your hands because you're going to start getting anything and you're going to start developing hair. I like to let your daughter do that. She's going to have a mustache. So do they really have hypogonadism where men are losing the vitality to this one that step? A lot of times that's what it is. It's the same treatment. But as men age, the total testosterone doesn't. Absolute contraindications for testosterone replacement therapy. Basically, that's what this is. Breast cancer, absolute no. Polycythemia vera. What is polycythemia vera? Viscous blood, very, very thick. Your H&H concentration should be 1 to 3. Good, 10 to 30. Polycythemia vera is more like, oh, adults have 30. If you're 10 to 30, they're like 30 to 90. That's thick, lot of blood. Prostate cancer, absolutely no testosterone there because we deprive you to do androgen deprivation in prostate cancer because it makes the cancer worse. Androgen deprivation. And then we'll look at your PSA, who think you've got prostate cancer. There's nodules in duration on a visual exam. Always refer to the urologist. Primary and secondary amenorrhea, what's the number one cause of primary amenorrhea? Would they look at the slide? Pregnancy, right? Number one. Number one cause of primary failure of any menses to appear at all. You might have an issue with hypothalamic pituitary axis, hyperandrogenism, ovarian dysgenesis, uterine issues, embryonic underdevelopment issues, sexual development disorders. You have a question? No? Yes.
We had in previous courses been taught that
Secondary.
secondary amenorrhea the number one cause is pregnancy, but I guess is this like in this case of like teen pregnancy vibe?
So you've already had failure for any menses, could they be different girls?
Yeah.
Yeah, that don't
Yeah.
even know they're pregnant.
Perfect.
Because the hinds that perforate and then they put in that blood in.
Yeah. Okay.
And they have no idea. Like, how did that happen? So you got pregnant, okay, that perforated the hymen, but there was somehow there wasn't any blood. I don't know how that happened.
Yeah.
But yes, secondary, there's always a board question on this. Always. Always. What's the, in Professor G saying the same thing. What is the number one cause for secondary amenorrhea? Pregnancy, absolutely. So this comes straight out of your textbook too, for this, but think of all these different disorders, but think of what the pituitary gland, the anterior pituitary gland is doing. It's FSH, FSH, FSH. Is it normal? Is it low? Is it high? It's just starting to determine cause. Now, secondary, you don't have menses, you've already passed menarche. And now you have cessation of menses for 3 months or more. So menopause is a point in time. Menopause that you go, oh, yes, when you guys go through menopause, you're like, oh, another period for a few months, oh, here it comes. And it's the worst thing ever. It's if you've not had one for a year, 12 consecutive months, and then your physician might test, estradiol or estrogen to see if you're really having stuff. Pregnancy is your number one cause of secondary amenorrhea. So you got HCG, you've got your hypothalamic pituitary cause, hyperandrogenism, uterine causes, menopause, again. In your treatment covered the cause. Then you're pregnant. But secondary amenorrhea is going to go away. That is all. Any questions? Any